Thank you very much for inviting me to talk at your conference today. It's a great pleasure to participate in this meeting. I'm going to talk about the multidisciplinary management of adults with Duchenne muscular dystrophy and perhaps raise some of the challenges that we have faced over recent years and what we have done to try and address them. So we have a very rapidly changing cohort of adults with Duchenne. When I started working at the National Hospital here in London, we had only 20 patients in 2011. We now have 165 adults with Duchenne dystrophy under our care. They range between 17 and 40 years of age. And what's very different about this population is that now 9% of our patients are still able to walk independently. 2% of patients are able to self-propel their own wheelchair and can transfer. And the oldest person living in the UK with Duchenne muscular dystrophy had his 50th birthday earlier this year. This is very different to when I first started in the field in the 1990s. So this new and growing population of young adults with Duchenne are quite different to patients that I knew in the past. My impression from talking to young men is that they now want to be seen as normal and they want to just get on with their lives. They're much more independent than their previous generations, and they're healthier than the previous generations of Duchenne adults. And because of these factors, they're likely to be less aware of the importance of regular follow-up in the hospital and of cardiorespiratory screening. And because many of our adults are now taking steroid treatment, their health needs are much more complex. In addition, I now have adult patients with taking novel treatments, in particular ataluren or Translarna, and also eteplirsen, which is an exon skipping drug. So in order to try and improve the services for adults with Duchenne dystrophy, about 3 years ago, I established a national network in the UK called the Adult North Star Network, which has been funded by the charity Muscular Dystrophy UK. Our network includes 18 centres of adult neurologists, respiratory physicians, cardiologists, and therapists looking after more than 650 adults with Duchenne muscular dystrophy. Our goal is to improve services for adults attending these centres. And to that effect, we have now developed our own standard of care, which was developed following a series of workshops with experts in the field. We are developing our standardized outcome measures, and we have developed a natural history database so that we can audit our standard of care and adapt that in the future. We also want to become trial ready for this population of patients. So our standard of care document, I'm just going to go back a slide to let you know that if you want to see it, you can download it from the British Myology Society website. It's free. But I'm not going to go through the document in detail because it's quite a large document and we're hoping to produce a version for lay people which will be easier to read. But if we were to summarize the key points that came out of this standard of care document, is that for each of the systems that are needed in terms of specialist care, what's really important is to have an expert, a consultant or an expert who knows Duchenne patients and who understands the problems that they get. And of course, care has to be proactive and anticipatory. And we're now having to bring in specialists from other areas, as well as cardiac and respiratory care. Gastrointestinal care has become a big part of our service. And now we're moving into renal care as well. So this is only part of our multidisciplinary team here, and we meet on a weekly basis. Our team includes a cardiologist, this is Antonis here, a respiratory physician, an endocrinologist, a neurologist, a gastroenterologist, physiotherapists, occupational therapists, speech and language therapists. We bring in from time to time our pain team. We have a full-time clinical psychologist. And from time to time, we bring in specialists in palliative care and renal medicine. And over in the corner here is Javid, who is our specialist anaesthetist, who gives advice on general anesthesia. We don't have access to orthopedics at our centre, so we have to refer patients, unfortunately, to another hospital, but we do, through our physiotherapy team, provide orthotics. So you can see that it's a very complex package of care that our patients require. And as I've said, this is a changing natural history. So of 119 patients, you can see that 82 had been treated with steroids and 37 had never had steroids. But of our steroid-treated patients, you can see that the length of time they were treated varies from 1 year to more than 10 years in the majority of patients. And if we then look at the effect of those who are still on treatment when they reach the adult service with those who had previously been steroid treated, what you can see is a marked improvement in the respiratory care of those who are still taking steroid treatment. In addition, you can see that the mean heart function, the ejection fraction, again, is better in our patients who are still taking steroids. And if we look at some of the other features of our patients, our steroid-treated patients are a little heavier, which is to be expected, than our non-steroid patients. But actually, what I would say for most of those patients, it's an advantage because some of our steroid-naive patients are very underweight. Less than half of our patients on steroids require non-invasive ventilation, compared with 81% of those who are not taking steroids at the time of transition. And you can see that the steroid-naive patients are more likely to have scoliosis. They're more likely to require feeding and nutritional support through a gastrostomy, and they're more likely to have bowel issues. All of our patients, steroid or non-steroid, are treated with cardiac medications as per the international standards of care. Our steroid patients, however, are more likely to have had bone fractures, they're more likely to have cataracts, and they're more likely to have kidney stones. At the moment, we're still looking at renal function, and we measure a blood test called cystatin C. So this data is a little early for comparison, but we're finding that for a number of patients, this value is mildly abnormal. We have had 2 patients who are non-steroid treated who have developed renal failure. Thankfully, we've been able to reverse this with intravenous and oral fluids. So you can see that our Duchenne population are really very complex and have very multiple healthcare needs requiring multiple specialists. And actually, most adult neuromuscular services are not really ready for this influx of patients. And quite often, there is a lack of coordinated care across specialists. So many patients will have to go on different days or even different hospitals to see a cardiologist and a respiratory physician and so on. And often these specialists do not talk to each other. And one big complaint that most of our adult patients have is that they have a lack of access to physiotherapy. So it's not surprising, therefore, that patients commonly fail to attend their appointments. And in fact, this has been noted in several publications. The first one here, an ENMC workshop, which reported from a USA group that 20% of their adults with Duchenne and Becker muscular dystrophy were lost to follow-up. Again, a Care NMD survey found that in the UK, this is about 5 years old, this survey, 1/3 of adults with Duchenne were not receiving their recommended heart and lung checks and had limited access to physiotherapy. And again, this final paper here was from Newcastle in the UK, and it was asking the question, why do patients fail to attend their appointments? So we decided to try and overcome this problem, and it's really not rocket science. Instead of sending the patient to see multiple specialists, what we decided to do was bring the specialist to see the patient. In other words, put the patient at the centre. We were very lucky in that our charity funded a new ward called the Neuromuscular Complex Care Centre, or NMCCC. And given that all of our Duchenne patients have to once a year at least have a sleep study where they're admitted, we thought it was sensible to bring all of the specialists to see them while they're admitted for that sleep study. So, for example, they will have their cardiac echo and see the cardiologist and so on. And this means that the patients get known very well by the team. They come into our ward every 6 months or 12 months. And so because of that, the ward becomes their first point of access. So when they've got a problem, they ring the ward. And we have found that this has been highly cost effective and in fact costs less than sending the patient to multiple outpatient appointments. And if we look at the outcome of these NMCCC admissions, what we found is a 60% drop in acute hospital admissions. 91% of our patients reported improved care, and the range of services accessible to our patients was greatly increased. So we think this is a highly successful model. And although it took a while to persuade our patients to come in, I think now they would not change things. But if we're talking about adults with Duchenne, it's really important we talk about transition, which is the preparation for adulthood, which is a key factor in encouraging good life choices in our adult patients. So transition is about preparing for adulthood, helping the young person to develop resilience so that they can maintain relationships, make healthy choices, manage their healthcare appointments, and make informed decisions. We recently did an audit of transition experiences of young people attending our neurological hospital over a 3-year period. We managed to capture 1,385 patients. And we had a 24% response rate to our survey. And we were looking at the impact of their condition on the transition process. What we found was that almost a third of these young people were either not in work or education. 60% had felt the condition had prevented them from achieving their academic or work ambitions. And a further 73% reported depression and/or anxiety. 83% said that their condition had had a significant effect on their social life, family, or hobbies. And 50% were still living with their parents at the age of 25. And 66% wanted to attend appointments with another person. And there are a number of themes that came through when we looked at the qualitative statements. But the most important ones were anxiety, wanting support to make decisions, a feeling of stigma, and a feeling of isolation, and the need for peer support, which came out very strongly. There have been many documents published in many countries on transition. In the UK, we have something called NICE, which is the National Institute for Clinical Excellence, and they have produced guidance which is summarised in the British Medical Journal. And I think it's typical for all transition documents that you might see. It's really important that actually families and young people are informed as early as 12 years of age. It's no good waiting till they're 16 or 17. And by the time they're 13 or 14, they should start being involved in a transition plan. They should be treated as an equal partner and supported to make their own decisions so that we can foster independence and agree goals. As clinicians, we should link with social care and education And ideally, there should be a transition coordinator, and the young person should have a health plan or passport that's reviewed annually. It's really important to involve young people in service design. And again, peer support is crucially important for this group of people. So it's really important when we see young people in the pediatric service to encourage them to think about the future and to encourage them to focus on what they can do and not what they can't do. We set them goals, for example, to know what their medication is and why they take it. And we try and encourage them to plan for the future, particularly for higher education and employment. Participation is a key element of transition, but also for caring for adults with Duchenne. And in order to prepare for that, it's really important to encourage the young person to develop a circle of friends that will continue those friendships once they leave school. Team sports are very good, such as wheelchair football, hobbies, education, and pets. And of course, encouraging the young person to go on to higher education, I think, is a really good choice. People look at me in amazement, particularly teenagers, when I say, what are you going to do when you leave school? Because I don't think it had really dawned on them that they might get a job. But we should be encouraging them to think this way, encouraging to think how they're going to get around: public transport, drive yourself, walk around the street, or get someone else to drive you. These are choices that people can make, as is the choice of living independently with support, which many of our Duchenne adults do. And we have several Duchenne patients now who are in relationships and who have children. In terms of peer support, our clinical psychologist has established a young persons group for people with neuromuscular disorders. So it's girls and boys, not necessarily just Duchenne patients, but this has proved very, very popular. And they meet every fortnight. And because of COVID, they're now meeting via Zoom. And this has been a really successful group. And of course, charities. So in the UK, we have the DMD Pathfinders, a charity of for adults with Duchenne that provides very good peer support. So just to summarize, I think it's important to understand that adults with Duchenne dystrophy are much more independent and healthier than they've ever been before. Preparing young people for adulthood with Duchenne is now essential. And if we do not give them a good experience when they attend hospital, it's quite understandable that they will fail to attend. So they've got to be perceiving benefit. And their care needs to be proactive, multidisciplinary, and coordinated. And I think we really need to develop centres of excellence for adults with Duchenne that will be key to improving care further in the future and developing clinical trials for adults with Duchenne. So thank you again for listening to my presentation. It's been a great pleasure to talk at your conference, and I'd be very pleased to take questions later on during the Q&A session. Thank you again.